intestinal and atrial protozoans. Intestinal amoeba, so the life cycle and pathogenicity. So we have a life stages. So it starts as a cyst stage. It's infective, environmentally resistive form. It's transmitted through ingestion of feces, contaminated water, or food. It is non-motile and it is adapted for survival outside of the host. This is responsible for transmission of infection. Then you have the trophozoite stage. These are active, motile feeding stage inside the host. It moves using pseudopodia and ingests food. Can cause tissue damage and symptoms during infection. Important species for this is Entamoeba histolytica. This is the most significant pathogenic amoeba in humans. It causes amoebiasis, which can lead to intestinal and extraintestinal infections like a liver abscess. Diagnosis would involve detecting cysts or trophozoites in stool samples. With the life cycle of Entamoeba histolytica, there is ingestion of the cyst. Once they are in the small intestine, the amoeba will liberate from the cyst and form metacystic trophs. They enter the cecal region of the large intestine, and the trophs form into the cyst stage. The cyst stage can be found in formed or semi-formed stools. This amoeba is found worldwide depending on levels of sanitation. Entamoeba histolytica is more common in children over 5 years, more common in males than females, and often found in poor or in the institutionalized populations as well. The most common source is from food or water contaminated with the cyst. There are two different categories of disease. So we have intestinal and extraintestinal. So intestinal amoebiasis, so infection primarily affects the colon. For pathology, there's the formation of ulcers in the wall of the colon. The ulcers may cause tissue destruction, inflammation, and bleeding. For clinical features, patients will have diarrhea, which may be bloody, abdominal pain and cramping. They may have a feeling of incomplete evacuation, and possible presence of mucus and blood in stools. For the extraintestinal amoebiasis, this occurs when trophozoites invade beyond the intestine through the bloodstream. Common sites and manifestations include liver abscess. This is the most common extraintestinal manifestation. So trophozoites invade the liver, causing abscess formation. And the symptoms could include right upper quadrant pain, fever, and hepatomegaly. This can lead to serious complications if left untreated. You can also have cutaneous amoebiasis, which is cutaneous ulcers. So ulcerative lesions on the skin due to spread or direct extension. This is less common than the liver abscess. Other rare extraintestinal sites can include the lung, brain, and the spleen. So for diagnostic purposes, we're looking for identification of the troph or cyst in the stool, or the troph and aspirates from the wall of the intestine and the extraintestinal abscesses. Usually this requires a permanent stained smear. In the process of identification, there are 3 phases. So the first thing you're going to do is distinguish the amoeba from white blood cells, since they will kind of look similar. Then you're going to distinguish Entamoeba from other amoeba genuses. And then you're going to distinguish Entamoeba histolytica from other members of the Entamoeba genus. Usually white blood cell nuclear material versus cytoplasm ratio is 1 area of nuclear material to about 1 to 1.5 times your cytoplasm. Whereas within amoeba, we're going to have much more cytoplasm. So that's kind of how you can differentiate between white blood cells and amoebas. So it's a 1 to 3 nuclear to cytoplasmic ratio. There are serologic tests available for Entamoeba histolytica. There are pathogenic and non-pathogenic strains as well, and they actually can both be found in the same patient. One of the things to always remember for Entamoeba histolytica, it is the only amoeba that will ingest red blood cells. So if you find an amoeba and it has ingested red blood cells in it, you know you have Entamoeba histolytica. So if you look at the picture on the slide, you can see those kind of black dots within that organism, and that is actually the red blood cells that it has ingested. Blastocystis hominis is an intestinal protozoan that was long considered to be a yeast due to its round, vacuolated appearance in stool specimens. However, advances in ultrastructural and molecular analysis have confirmed that Blastocystis is actually a protozoan, not a fungus. So this misclassification persisted for decades, primarily because of its unusual morphology and the lack of visible movement in most forms under light microscopy. Unlike yeast, though, blastocystis is capable of extending and retracting pseudopods and reproduces asexually by binary fission, which further helps to support its classification as a protozoan. The morphological forms, so Blastocystis hominis exhibits 3 morphological forms, each with a unique characteristic that can appear in stool samples or during laboratory cultivation. So we have central body form. This is the most commonly observed form in clinical samples. It presents as a round cell with a large central fluid-filled vacuole that pushes the cytoplasm and nuclei to the periphery. Under the microscope, the cell appears almost completely empty, hence the name central body form. The peripheral cytoplasm is thin and often difficult to distinguish clearly, which historically contributed to the confusion with yeast cells. Then we have the amoeboid form. So the amoeboid form is less commonly seen but becomes more prominent in diarrheal stool. This form can extend pseudopods, allowing it to move in an amoeboid fashion. It closely mimics leukocytes, particularly macrophages, in diarrheal fluid, making it difficult to distinguish from host immune cells during microscopic examination. This form is often associated with symptomatic cases and may represent a more invasive stage. Then we have the granular form. So in the granular form, the cytoplasm is densely packed with numerous mitochondria and other granules, giving the cell a coarse or solid appearance under the microscope. This form reflects a metabolically active phase and may appear as a ball of granules. It is most commonly seen in culture or during active replication phases and is less frequently identified in direct stool smears. This is found in the United States, in travelers and oftentimes in AIDS patients. It is a fecal oral route through contaminated food or water, and there's still discussion about whether if this is truly a pathogen or not. It can be recovered with a wet mount and a trichrome stained smear for stool. It is usually brightly refractile and has a variable diameter of 4 to 15 micrometers. So again, we're looking for the microscope that has the ocular micrometer on it so we can measure it. The central body is usually empty, so we'll have a narrow rim outside of plasma that contains the nuclei and inclusion bodies. Don't make your wet prep with tap water because that can cause it to actually rupture. And then we have Giardia. You will see literature and maybe even certification exam questions still refer to this as Giardia lamblia. However, it is now called Giardia duodenalis. So make sure you know both names and know that it's the same, specimen. There is a flagellate. Typically, it's transmitted by ingestion of mature quadranucleated cells, or cyst, cyst walls removed and become 2 binucleate teardrop-shaped trophs, each that are propelled by 4 pairs of flagella. So you have, if you kind of look at it, you can see the 2 looking eyeball things. So you had 2, and now it's combined into 1. The troph attaches to epithelial cells in the duodenum and the upper jejunum. The cyst formation starts when the trophs are carried in the feces to the large intestine, and then we get dehydration of the feces that provokes formation of the cyst. Giardia lamblia is found worldwide and is one of the most common intestinal protozoan infections. Transmission typically occurs through ingestion of water contaminated with sewage or by drinking from streams and rivers polluted by the feces of infected wild animals, especially in mountainous or wilderness areas. The infection can affect individuals of all ages and is particularly common among travelers, campers, and children in daycare settings. Clinically, about 50% of infected individuals remain asymptomatic. In symptomatic cases, the infection can cause acute gastrointestinal illness characterized by watery or greasy diarrhea, flatulence, epigastric pain, nausea, anorexia, and abdominal cramps. Symptoms may be self-limited or persist, leading to chronic infection and malabsorption if untreated. So our diagnosis is based on visual identification of a cyst or troph found in the feces. It may require several specimens. If you do a wet mount of Giardia, you'll see what we call a falling leaf motility. You can also do a permanent stain, which has a typical teardrop shape, a binucleate troph. Lots of times I think it looks like a tiny face. It's kind of one of my favorite ones to look at. And sometimes they are also referred to as the old man because they kind of have that look to them as well. It has 2 nucleoli on either side of a pair of axonemes and the pair of median bodies that are located in mid-body of the organism. So that would be considered the troph. Once it becomes a cyst, it's more of a football shape with 2 to 4 nucleoli found in there. You will see retraction of cytoplasm from one end of the cyst wall, and we do have enzyme immunoassays available for diagnostic purposes now as well. Trichomonas vaginalis. This exists only in the troph stage and has an axostyle and an undulated membrane. You will see that the membrane in motion when you do a direct mount. So if you remember back to your urinalysis class, you may remember seeing or hearing about trichomonas. It inhabits the urogenital tract and is passed through sexual intercourse. Once it is in the urogenital tract, it will divide longitudinally. Found in sexually active groups in all climates and in all races. In males, Trichomonas vaginalis infection is usually asymptomatic, though some may experience mild urethritis or discharge. In females, symptoms are more apparent and may include vaginal itching or burning, dysuria, and a frothy yellow or greenish vaginal discharge with a possible foul odor. The degree of inflammation and discomfort can vary. For laboratory diagnosis, it is commonly made by examining a wet mount of vaginal or urethral discharge in females or urethral discharge in males. The characteristic finding is motile trophozoites exhibiting jerky, non-directional motility under the microscope. Prompt examination is essential as trophozoites lose motility quickly outside of the body. Neoballatidium coli is the new genus name. It used to be called Ballatidium coli. So this is a ciliated protozoan. It basically has like little hair-like projections on the cell wall. The life cycle is very similar to Entamoeba histolytica. It's infective in the cyst stage, and they migrate to the large intestine. They rarely invade beyond the wall of the intestine or produce extraintestinal disease. It is rare, but it is found worldwide. And a lot of times it's found or can be transmitted person-to-person contact or people who have close contact with pigs. With Neoballatidium coli, most infections are asymptomatic, or maybe they have like an intermittent diarrhea with some constipation. In more severe cases, the symptoms will be dysentery, abdominal pain, nausea, vomiting, fever, headache, and insomnia. Laboratory diagnosis is usually by identification of a cyst or troph found in the feces. So the troph will be covered with rows of tiny cilia, 30 to 120 micrometers long, and it's 25 to 120 micrometers wide. Size will vary based on the amount of how much was ingested within the food material. It is usually an oblong with a slightly pointed anterior end with a rounded posterior. At the anterior end, you may be able to see a V-shaped groove that actually is the pharynx in the mouth of the organism. Cysts are rounded and usually 50 to 70 micrometers in diameter. Once that cyst matures, the cilia will disappear. The wet mount is your preferred method for identification, and what we're looking for is a troph with a boring type of motility. Cryptosporidium parvum infect a wide range of animals and birds, making them important zoonotic pathogens. They are particularly significant in immunocompromised individuals, such as patients with AIDS, where the infection can cause severe chronic diarrhea and systemic disease. Transmission occurs primarily through the ingestion of infectious oocyst present in fecally contaminated food or water. Additionally, cryptosporidium can be spread via oral anal sexual contact or through direct contact with infected persons or animals, emphasizing the importance of hygiene and safe practices to prevent infection. Patients infected with cryptosporidium may be asymptomatic or experience a mild self-limiting illness characterized by watery diarrhea with mucus, nausea, vomiting, malabsorption, and fever. In immunocompromised individuals, especially those with AIDS, the infection can become severe, chronic, and potentially life-threatening, causing persistent diarrhea and significant dehydration. Laboratory diagnosis will involve identifying small, oval, or round oocysts in stool samples. Due to their size and morphology, special staining techniques are required for visualization, including the modified acid-fast stain, Giemsa stain, and direct fluorescent antibody techniques. So the modified acid-fast stain, this is the standard and most widely used method for visualizing cryptosporidium oocyst. The oocysts stain bright red or pink against a blue or green background, making them stand out clearly. Unlike typical acid-fast bacteria, Cryptosporidium oocysts are only partially acid-fast, which is why the modified or cold acid-fast method is preferred. This technique is cost-effective and relatively simple, making it ideal for routine diagnostics. For the Giemsa stain, although less sensitive than the acid-fast staining, Giemsa can be used to detect oocyst. On the Giemsa stain, Cryptosporidium oocysts appear as round to oval bodies with a basophilic, which is that blue to purple cytoplasm. This stain is helpful when parasites are seen within intestinal epithelial cells or when multiple parasite types are being investigated in the same sample. For direct fluorescent antibody, this is a highly sensitive and specific method that uses fluorescent labeled antibodies that targets Cryptosporidium antigens. When viewed under a fluorescent microscope, the oocysts emit a bright green fluorescence, allowing rapid and accurate identification even in samples with low parasite loads. Although direct fluorescent analysis is more expensive and requires specialized equipment, it is increasingly used in clinical laboratories due to its superior accuracy. Another method that could be used is immunochromatographic assays and PCR-based techniques. These are less commonly used for routine stool examination, but they are out there.